If you could tell somebody who's unfamiliar with hospice what is most impactful and necessary, uh, and I include in this the idea that hospice shouldn't be a last minute decision.
Right. Yes. So, that's such an interesting question because I used to have a very different way to talk about hospice. Um, but what I tell people now, mostly I start with saying, you've already paid for the service. You've paid for the service by, when money's taken out of your paycheck all these years to go to Medicare. It's for the Medicare, the insurance that you get when you turn 65, but also part of this benefit goes to paying for your end-of-life care. So that you don't need to go back and forth to the doctors. You don't need to be running around like getting tests. If you are at the point where you feel like, I don't want to do that anymore. I want to be at home. I want to be with my family or friends, and I want to be out of pain and comfortable. Um, that would be the time to think about hospice. Hospice is a wonderful benefit. Most people don't realize that they've already paid for it. So I've kind of said to some people, it's like you save up your whole life for a vacation. Now, this may not be the vacation you have in mind, but you have saved up your entire life, every paycheck. You've saved money for this experience you're about to have. And so then you get to use it for your last 2 or 3 days of your life or your last week of your life, um, when you could have it for 6 months or more. And initially people are like, well, why wouldn't you do everything you could to live? And I think, in hospice, we do everything we can to have that person live their life as fully as possible without having to be a medical sort of species. We try not to relate to people as their medical disease. Death is not a medical, it's not a medical event. It's really a psychosocial, spiritual event. But in our country, we've landed it kind of this medical, and it's not to say that having excellent symptom management, that is very important. Having great pain management, that is very important. But being with people that care about you is also very important. We've seen this recently with COVID. I had an experience with my neighbor whose father had been quite ill for a number of years, but just at the very beginning of COVID, he had an incident where he landed in the hospital, and nobody in their family was allowed to see him. This was a gentleman who had raised 7 children. He had married when he was a teenager, still married to that same person. He had never been alone in his entire life. He was a veteran. He served. He was always surrounded by people, and he sorry about that. A friend just dropped by. My friend whose dad I'm talking about. But this gentleman had never been alone in his life, and now he is disoriented. He's not really sure what's happening. He's in a hospital room. That his wife can't see him. His children can't see him. And I said to my friend when she told me about this, because she was down in Southern California at the time hoping to see her father, I said, I know that you may or may not feel that this is the right thing to do, and I know that your family isn't interested in hospice right now. But if you're able to talk to your father's doctor and say, would you be surprised if he died in the next 6 months? And if your doctor, and his doctor says, no, that wouldn't surprise me at all, please ask your doctor to send a hospice referral, have him come home where your whole family can go and see him as safely as possible, but at least he'll be home in his own bed. Your mom can explain to him what's going on, and your sister who lives in the house will be able to care for him. And that happened, and their dad, he actually graduated from hospice, so he is still alive. And they are so grateful that they were able to spend time with him, because in the hospital they couldn't at all. So that happened. I suggested this to a number of people whose parents were quite ill, and they did end up being able to bring them home. One died, this other one did not. But what they were most grateful for is that they were able to be together as a family, even in the middle of COVID. And they would have a nurse come out as carefully as possible. The doctor would come, the other team members. So in hospice, for those that aren't familiar, not only you're getting your medical needs met, so you'd have a doctor, a nurse, case manager, a social worker. And a lot of times people are like, why would I need a social worker if I am, here? And one of the reasons is because the social worker's job is to really look at the big picture of what's happening and see where might somebody benefit from some more support. Does this person need more caregiving support? If there's a family caregiver, do they need just a time off where they could go and sit outside in the garden or take a nap? And so if that's the case, maybe a volunteer these are all highly trained people who just come and spend time with the person, either to provide just a presence. The person doesn't need to engage with them. Lots of volunteers just might sit in the room or sit in the living room while the spouse goes out or the daughter or son goes out to take a break. There's also one of the most wonderful parts about hospice, and I saw this earlier this year when my mom, very out of the blue, had a couple of incidences and then in 10 days' time died. But the home health aides, or as we refer to them sometimes in hospice, the bath aides, will come and provide the personal care for people. It was such a relief. I've been doing this work for 32 years when my mom got sick and was dying. And having that home health aide come in and do the bed bath, wash her hair, get her comfortable, be able to change her clothing. My mother just said, this is the best thing that's happened. I mean, she was only sick for a few days, but we've had families that have, that's such a burden for a family member to have to do, particularly a child caring for a parent. Just in terms of modesty, if you have to change your parent, you do what you need to do. But in terms of having to give a bath or something like that, for many parents, it just doesn't feel right that their child is doing that, no matter what age the child is and what age the parent is. So to have a home health aide or a bath aide come, it's a miracle for a lot of families. And then the volunteer is wonderful. And also, the support that people get as they're navigating the anticipatory grief that comes from caring for a loved one that you know is going to die, and the bereavement support afterwards from the grief programs that hospice provides, those are lifesavers for people. After a death happens, particularly if you've been a caregiver, there's just a sense, like the hospice team that's been coming all the time, they're not coming now. The connecting somebody with the bereavement team before the death happens so they know there's people waiting for you when you're ready to engage in whatever way you want to with a group support or phone calls or counseling, when we can meet in person again in person, but if not, on a phone call, now in Zoom meetings. That lifeline often really, really makes all the difference in the world to the family members that are navigating the post-death experience. As one woman said, my husband and I talked about everything before he died. We had it. We talked about everything. There were times where we were fighting about stuff. There were times when we were laughing. There were times when we were crying. But it was all good. And she said, I feel like at 70-something years old, my greatest achievement in my life was being able to be there as a caregiver for my husband in the way that he wanted it and not the way I thought it should be. But what nobody told me is once he died, I was have to do this by myself. And so without the support of the grief team, the bereavement team, the counselors, people can feel really adrift. And at Mission Hospice, because we've had the education programs, once people kind of get through their grief, not that people ever get over their grief, but through at least the really acute part of their grief, we find a lot of times people will come to the movie night or now look on Zoom at the movie night or come to a speaker night and start to connect with other people that are there and build a community for themselves. And that is a beautiful thing to watch. People kind of coming out of this really dark and hard period and kind of seeing light again for themselves and giving themselves permission to feel connection to new people, to be able to integrate the death of their loved one and that loved one into their life now, because people die but love doesn't, and people continue often to have relationships long after that person is dead. I'm getting goosebumps now because I feel like, I feel like I've really lived in California too long. I'm getting goosebumps talking about this because I feel like, as I say at almost every death cafe, we're here in this room because people we love have died. And I don't feel that they're ever very far from us. So I try to acknowledge that in the death cafe when we close, that all of these people are still, their memories, however we want to refer to it, our relationship with them very often continues for years and years after that.
Let me circle back a minute. One of the concerns that I end up at, and this is kind of where I started before, is that people wait too long and it's too late. And the average hospice stay, the last time I saw a number was like 2 days.
I think it's about 10.
Is it now 10? But
yeah, which isn't much better. I mean, because when you
no,
figure your hospice admission happens, and then the next day your nurse case manager, who's going to be your nurse, will come, and Then you need the social worker, even if that's just a phone call, a spiritual care, if people are interested in that, a volunteer. The first couple of days on hospice can be very overwhelming for people
Oh, I can imagine.
because of the amount of contact. But then most people, and I would say this is probably true, at least in our hospice program, probably 98% of the time, people realize, number one, hospice isn't there to kill me. I mean, we still have people say, I don't want hospice because, when hospice comes, they just give you morphine and then you die.
Yeah, it's a death panel.
Yes, right. Well, good Lord. That's a whole other conversation. But,
Well, yeah.
to the very end of your life to involve hospice, number one, if you're going through this and you have a family caregiver, um, having hospice involved can be one of the most supportive things you can do for your family caregiver. I've done this work for 32 years. When my mother was dying in January, some of my siblings didn't believe she was dying for a number of days. I was pretty clear from the time I got there. She was living in an assisted care facility, so there were caregivers downstairs. And we got a hospice involved after the first maybe 4 or 5 days because it was a holiday, so they couldn't come on the holiday. We come out on holidays, but this one couldn't. But when they showed up, having the hospice nurse, somebody to call, even though I've done this a long time, there were things that, I'm also my mother's daughter, so I wasn't like showing up as a hospice, anything. I was showing up as my mother's dying. We've had a terrible relationship. Now in 5 days, it's completely turned around, and now in 5 more days, she's going to die. So I called that hospice 3 times the night she was dying about medication changes. The caregivers, I was so grateful I could call on the phone and have somebody come. But having the ability to call somebody, have somebody pick up the phone and say, oh, yes, this is what's happening. This is how you can deal with it. Here's the medications that you need. And if you'd like me to come out right now, I'll come. That is such a gift. And I was so grateful that we had hospice and that there were, somebody on the other end of that telephone.
Right.
Yeah, so waiting till the very end of somebody's life to engage hospice.
Well, it's a matter of, I think, 2 things. Doctors hesitant to say, and then family unwilling to accept, there's no cure.
Right.
And looking at hospice as giving up, or as you're saying, not ready to die.
Right.
And yet hospice often, or palliative care of any sort, is often more successful in prolonging life.
That's correct. Yeah. Well, I
s-
think the important thing about that is not just that so there's been a number of studies, and I wish I could talk to you about which exact study this is. There's a number of studies that indicate that people who elect their hospice benefit is what it's called. You're electing, it's an insurance benefit. You're going to choose your hospice benefit, meaning that you are no longer going to be aggressively treating your illness to cure it. That doesn't mean if you're diabetic, you can't keep taking your diabetes medicine. It doesn't mean that if there's something that we can do that will ease your comfort level, that we wouldn't go ahead even if it's a medical procedure. But in terms of trying to cure the person, that is no longer the goal of care. So,
but it's a signal of giving up hope for people.
so that's also a very interesting thing that you say there, because that is inaccurate also. So there's been studies done. We're actually hosting on January 14th. We're the second of our community conversations for January of 2020. David Feldman, who is a professor, a psychology professor at the University, Santa Clara University, and who I heard speak years ago on hope at end of life, will disabuse you of that idea. Research shows that people who are actually given the accurate prognosis for their illness, even if it's super hard to hear, do not give up hope. They readjust what they're hoping for. So if they're hoping for a cure and they're told they have a terminal illness, that there isn't any more medication or treatment or procedures that they could do to keep them alive or extend their life, that will come maybe as a shock for a day or 2 or 3. But human beings are incredibly resilient. And what the research shows is people adjust what it is they're hoping for. So, for example, we had a family that we cared for that was a younger man with with ALS, who had a couple of things that he really wanted before he died. His family, he had a young child at the time, had vacationed for many years in a tropical place. This is one of his great sorrows when he became our hospice patient. And the social worker and he and his family had many conversations about this. And what ended up happening is, instead of going to a tropical vacation land, which was not doable, with the help of the hospice social worker, found a place in the Bay Area where they could go. A hotel would take them with the oxygen, and we were able to get the hospital bed there because he needed that for his care and to get in and out of his. He just needed to have a hospital bed. They were fine with the oxygen being there, and he had a wonderful 4-day vacation with his family. They saw the beach every day, and he was so incredibly grateful for that. So, Hawaii or the tropics might have been out, but there's other things that people can actually do if they understand what their actual prognosis is. They're given the accurate information, and then they and their family can also decide what it is that's most important right now. And with the help of hospice, they often are able to achieve some semblance of that. We've had people go on cruises. We had a family where the woman, her goal was to go on a cruise. So we had her, think of it that she had to sign off of hospice at that point because it was out of our service area. We don't actually work in a cruise area. We connected her to a hospice in the area where she was going to be on her cruise. And she had a fantastic time, she and her husband, and as soon as they returned, we readmitted her to hospice. Now, that's kind of unusual, but she had a kind of illness. And this is also important for people to know, because you could have a cancer diagnosis and still be walking around, but at stage 4 with no more treatment, you might be walking around and be on hospice. You could have somebody with dementia where their criteria, the Medicare sets the criteria to come into hospice. That person may be laying in bed for months without being able to speak, but they may still be eating, or they may still be doing some other things that are not quite the criteria for hospice. And so that person may not be eligible for hospice, where the person that's walking around could be. And that's hard for people to understand, but the earlier hospice can be there, it typically means the person will have a higher quality of life for longer than their cohorts who continue to get treatment after treatment after treatment, even when it's futile and even when the doctor knows it's futile. So getting onto hospice sooner rather than later, for one thing, like my downstairs neighbor, her dad graduated. They got him in at home. He looked like he was going to die within the next 6 months. The hospice was able to really look at the medications he was on, readjust a lot of those medications, and speak to his doctor and get him off things that were really not working for him. And so he's been probably much healthier at home since hospice was there than he was before hospice came. Because, as is true for many people, if you're seeing an oncologist and you're seeing a cardiologist and you're seeing a rheumatologist, there's often a belief that those people are all chatting away with each other about your care. That almost never happens unless you have asked or sometimes demanded a palliative care consultation. Because a palliative care person, even if you're actively and aggressively treating your illness, their job is to look at who are you as a person, what is it that you value, what is important to you, what is important is, do you have caregivers, or is your family involved, what's important to them, and then really kind of have conversations and try to speak with the other other docs that are caring for that person, and try to get on the same page around the care that that person is really interested in. A lot of times I think people, my parents were no exception to this. My mother was an exception to this. My father was not an exception to this. If the doctor says to do it, that's what you're going to do. So if the doctor says chemo, that's what you're going to do. If the doctor says testing, more testing, you're going to do that. Often people don't understand that you could say, wait a second, I don't really want to keep coming back to the hospital. I don't really feel good when I come out of treatment. I don't feel good. And I don't ever feel good and then I come back and get more treatment, I would like to be at home where I want my symptoms managed. I don't want to be in pain, but I don't want to keep feeling like this all the time. And I think once people realize that they have some agency, and because they've paid into the hospice benefit, they can also select their hospice. It's not uncommon that doctors or hospitals will recommend a hospice that they're just used to, or that they work with, or that there's some other reason they're referring to them. It's very important that people understand that maybe I don't want that hospice. Maybe I want a not-for-profit hospice. Maybe I want a hospice that exists because two people in the community that I'm living in formed that hospice 40 years ago, because one of them was sick just like I am and did not want to die in a hospital away from their friends and family. So, knowing what this is part of the, my goal in terms of community education is that people understand that there are options for them, what to think about, what to ask about, how to consider these things, try to figure out when is the right time to stop treatment. That question, I was told this decades ago. Ask the doctor, would you be surprised if so-and-so was dead in the next 6 months? And if they say no to that, chances are you're hospice eligible. Chances are also that the doctor, this is the other thing I think. There's a wonderful film by Jessica Zitter, a wonderful doctor from the Bay Area, called Extremis. It is on Netflix. It is free to watch. It's about 28 minutes, and it shows what happens when people show up in hospitals without having conversations with their families about what's important to them. It's hard to watch this, but what I came away from, other than really admiring the work that was being done by this palliative care team, is how fraught these decisions are also for doctors, because they care about these patients. They care about what happens, and they want to do what's right. And they don't know what's right if nobody's ever had a conversation with their family members or with their own personal doctor. So the palliative care team can really help suss out some of these things. And maybe the person does want to be at home. And I have to say, people have this idea that hospice is like, well, there's just no medical care. It's probably the most cutting edge and the best quality care that somebody who is at their end of their life can possibly get. So, I recommend people find doctors that are willing to be their collaborator in their health care. And that is hard to find these days, but there are definitely doctors out there that can be your collaborator. And palliative care doctors, especially for people in the hospital or who are navigating chronic or long-term conditions, to ask for palliative care and see if there's outpatient palliative care that you'll be able to make use of. Medicare and insurance companies are all trying to figure out how do we pay for this, because palliative care really can really support people going through really difficult medical situations. How that all gets paid out is all kind of a puzzle. So it's being worked out. But in hospitals, almost any major hospital has palliative care, at least a doctor, usually a team. And the palliative care team can look a lot like a hospice team. There may be a social worker or a counselor or spiritual care person that will come to visit, in addition to a doctor or a palliative care nurse.
Well, that's kind of the thing too. As you said, you've had people that graduate from hospice.
Oh, yes.
And that doesn't mean they are done with comfort care.
No.
So, and
No.
then they may still be readmitted to hospice at some
Well,
point later.
at some point, unless they have a sudden death, absolutely, yes.
So, but that
Yeah.
continuum of care, it doesn't really change.
No.
It's more definitional, if you will.
Yeah. We actually, at Mission Hospice, we have a program called Transitions that we offer to people in the community. There's no cost, and we're not reimbursed. This is something that the wonderful people of San Mateo and our donors support. So for people that might be a year out from their death, but still want to aggressively treat their illness, or who have been sick for years and maybe older adults, or may have just gotten a diagnosis, but they are like, I'm going to try some chemo, I'm going to try this. So Transitions program provides a psychosocial support. There is a nurse that runs that program. She meets with all of the people who we serve on that program and the families. And then there's a social worker, usually support, because often people who are navigating illness have a lot of how am I going to get my groceries? How, like, I have to go to the doctor twice a week. How am I, or I have to go for this treatment twice a week. How am I going to do that? You know, and instead of having to figure that all out by themselves, the social worker can really help.
Mm-hmm.
The social workers are also very helpful in terms of looking at, like, financials, in terms of, like, okay, if you need to hire care, like, what's realistic in terms of, you know, what can you afford and what can you afford to pay and those sorts of things. But the transitions program has also been really good for patients who we discharge from hospice, because they don't, a lot of people after getting hospice care, they feel like kind of wrapped up in a warm blanket. And then if Medicare, they don't qualify for hospice anymore, they have just maybe plateaued and their illness isn't, they're not declining anymore. So often they'll go into our transitions program so that we're still connected with them.
Mm-hmm.
And if they have a volunteer, the volunteer can still visit them. You know, it can be very helpful just to keep track of people.